Ladies and gentlemen, it gives me great pleasure to welcome all of you in this series of webinars I'm organizing as treasurer of the World Federation of Neurosurgical Societies, the WFNS, in collaboration with the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies, the CANSA. I'm glad to tell you that we already organized 52 webinars, 16 out of them were educational WFNS Symposium. Today is webinar number 53, and I'm glad and honored that it's organized in collaboration with the Ukrainian Association of Neurosurgeons. In this occasion, I would like to thank Professors Andriy Hook and Professors Vladimir Smolanka for the opportunity to have such wonderful collaboration. Let me first welcome all our distinguished speakers. I will go by the order by which they speak. Professor Orest Palamar, he is Deputy Head at the Endoscopic and Craniofacial Surgery Department, Romodanov Neurosurgery Institute. Professor Volodymyr Spolanka, he is president of the Ukrainian Association of Neurosurgeons, and he is rector of the Uzuhord National University. Professor Andriy Hook, he is secretary of the Ukrainian Association of Neurosurgeons, and he is head of the Endoscopic and Craniofacial Surgery Department, Romodanov Neurosurgery Institute. Professor Uri Lontkovsky, he is director of the Medlo Medical Center at Ukraine. Professor Boris Pavlov is affiliated to the Neurosurgery Neurospine Clinic. And finally, Dr. Lakiv Fishenko, he is affiliated to the Institute of Traumatology and Orthopedics, National Academy of Medical Science, Ukraine. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time, sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic, is well appreciated. Our program today is outstanding. We have two sessions. In each session, we have 3 speakers. The first session will be about skull-based surgery. The second session will be about minimally invasive spine surgery. And as we can see over the screen, we have very interesting topics that will be presented today. This screenshot shows that the registrants until yesterday over Zoom to this event are 423 registrants. We are also doing live stream over our Facebook page of the Continental Association of African Neurosurgical Societies. The address is seen over the screen. We are doing live stream over the YouTube channel of the Egyptian Society of Neurosurgery, and we are doing live stream over the Neurosurgical TV. In this occasion, I would like to thank John Bennett. He is doing a great job in promoting our webinar series. To all attendees, we are glad to get all questions and comments, and it will be monitored through the chat panel or the Q&A. We are offering this type of certificates. You can print your certificate electronically, just allow 2 weeks in order to upload all emails to our system. The link is seen over the screen. The username will be the email by which you register to this webinar, and the password can be seen over the screen as well. Important to announce that webinar 53 will take place on Friday, 26 November at our usual time from 2 to 5 p.m. Egypt time. It will be a collaboration between Professor Atul Goel, is a well-known eminent neurosurgeon in India. I'm also glad to tell you that the Pan-Arab Journal of Neurosurgery is already relaunched after a period of silence of 10 years. I'm honored to be the editor-in-chief of this journal. We already published an issue on June 2021, The second issue will be published soon after a few weeks in December 2021. This is the address seen over the screen. All submissions are welcome. Please submit your articles. The submission and publication are both free. Important also to announce about the World Congress, which is organized by the World Federation of Neurosurgical Societies in Bogota, Colombia, 13 to 18 March 2022. I encourage all of you to participate in this great event. Another announcement is the Third Men's Congress, which will take place in Egypt from 27 to 30 October 2022 next year. I'm glad to be the president of this Congress and to work with Professor Alberto Delitala, who is president of the Mediterranean Association of Neurological Surgeons. All of you are invited. I think it will be a good opportunity to visit together the Grand Egyptian Museum. Thank you very much. Now I'm glad to give the talk to Professor Andrew Hook in order to take his to say his welcome note, and then we start our scientific sessions.
Again, good day to everyone. Thank you for joining this webinar. So it's called the webinar number 53. I guess that next one will be 54. And I'm very glad that in collaboration with FNS and with Egyptian Association and with CANS, we really have a good collaboration and can present our experience. I think it's very important because it means that neurosurgery has no any borders in the world. So it's not depends on the countries, it depends on people who are neurosurgeons and who would like to provide best care and up-to-date modern neurosurgery to our population, to our all countries in all the world. And doesn't matter it's country from low income, middle income or high income, because we are doctors, we are trying to do our best, take our knowledge, take what we achieve at what you can do by our hands with up-to-date equipment and up-to-date approaches to see how our patients. So even I started my career in neurosurgery 29 years ago, and it was completely different situation. And now we see it's really neurosurgery break the borders, and we can talk to everyone from our societies. It doesn't matter from continental, from different continents, and I am very glad that we really have this opportunity. Thank you, Nasser, for doing that, and thank you for FNS, and thank you for all who really would like to contribute and to make at least for our patients' life better.
Thank you very much, Dr. Andrew Hook, and this webinar will be moderated by Dr. Andrew Hook and by myself. And now it's time to start our scientific sessions. May I ask you to introduce Professor Smolanka?
Yeah, we start from Professor Smolanka. It's president, now past president of Ukrainian Association of Neurosurgeons and rector of one of the famous and best universities in Ukraine, Uzhgorod National University, and also one of the best neurosurgeons in Ukraine. And I am very glad that he find out time for his presentation. Thank you. Please, Professor Smolanka.
Yeah, thank you very much. Good afternoon, dear friends. I hope you hear me.
Yes.
Yeah, I will share my screen to show my presentation. Let me know, please, Andrei, whether you see the presentation.
Yes.
Yeah.
Yeah, for full screen, please.
Yeah, I will make it for full screen. Okay.
Yeah, good.
So, dear friends, Thank you very much for inviting me to be a part of this excellent series of webinars, which are organized by Professor El-Ghandour, and we appreciate your contribution to the world of neurosurgery, to the progress of neurosurgery. Thank you very much for this. Many thanks to John Bennett, who makes an excellent advertisement of this series of webinars. Dear friends, I see some greetings from the chat, and I see that we have almost 100 participants now. And let me share my experience with you concerning a very interesting and challenging topic, which is surgery of brainstem cavernomas. So I will begin with the description of the cavernous angiomas, which is one of the 4 vessel malformation of the brain. And it is a proliferative vascular malformation, which consists of numerous caverns, which are covered by very thin endothelium. And these malformations, they consist blood, which is surrounded by gliosis and hemosiderin because of the hemorrhages. I have to say that blood flow in this malformation is very slow. That's why these malformations can't be seen angiographically. Concerning the epidemiology, I have to say that almost 20%, so 1/5 of all cavernomas are located in the brainstem, and this is the most challenging part of the surgery of the brainstem cavernomas and the treatment of the brainstem cavernomas. That's why I will concentrate today on this topic. Some general considerations. Usually, brainstem cavernomas are presented with hemorrhage, and in this case, we have a cranial nerve deficit in all of cases. Some other focal neurological deficit, ataxia, in more than 40%. We have a sensory deficit, and in every 4th patient, we have a disturbance of consciousness. This is a natural history of different cavernomas, which were published in the excellent meta-analysis. And you see the difference between the in hemorrhage rate in brainstem cavernomas and in supratentorial cavernomas, so infratentorial and supratentorial cavernomas. It's really significant. That means that once the infratentorial cavernomas or brainstem cavernomas will bleed, they will bleed second time. And this is another topic, another article which was published by Ulrich Sure group from Essen, from Germany, about the risk of hemorrhages. And you see that there is a significant difference in risk of hemorrhages between brainstem group and the supratentorial group of cavernomas. So that means that the rate of rebleeding after the first bleeding is up to 60% per year. Someone says that it's just 20%. Someone says that it's 25 or 27 or 30%, but it depends on cohort of the study of the patients. But I have to mention that the rate of the secondary bleeding is extremely high. And if cavernoma bleeds once, it will bleed the second time. And if it bled 2 times, it would bleed the 3rd time. And usually it will be in 1 or 2 years. So this is a diagnostics of brainstem cavernomas, and you see here the typical picture. It's like popcorn ball structure with mixed hyper and hypointense blood containing locules. It depends on how many hemorrhages did this patient have, and surrounded by hypointense hemosiderin ring, as you see here, and this thin hemosiderin ring. But I have to state that this hemosiderin ring in tissue is in normal tissue, and then we remove the cavernoma. We don't touch this hemosiderin tissue because we always take it as a functioning tissue. There are some sensitive hemosiderin sensitive sequences like T2 gradient echo, but that's mainly for supratentorial cavernomas. There are different treatment options. The first option is observation. This for asymptomatic patients. Then this cavernoma is just incidentally found in the brainstem, or those with very deep lesions in the brainstem after the first bleeding, but I will touch this topic a bit later on. Radiosurgery is not effective, efficacy not proven, and that's, in my opinion, the mistake which is done by some urologists and even sometimes by neurosurgeons. Then they send these patients to the radiosurgery, which is not accepted, especially in brainstem cavernoma cases. And the third option, and I would say the second option, is the surgery, and we will talk about the indications for different patients. So you see here the cavernoma, which is located on the upper part of the pons and just on the edge of the midbrain, and it's deep-seated cavernoma. It's what to do to operate or not to operate such a patient, and we will discuss it with you, and we will analyze it a little bit later. By the way, the first surgeon who operated on brainstem cavernoma was a genius, one of the genius of neurosurgery, Walter Dendy. And can you imagine that almost 100 years ago, this brilliant neurosurgeon published the information about the removal of pontomedullary junction cavernous malformation in young men who had right leg stiffness, almost 100 years ago. This is a meta-analysis which reflects the results of the surgical treatment. And you see that there is a difference between surgically treated patients. Most of them showed good neurological status in long follow-up. And only 13% of these patients worsened after the surgery in analyzing the long follow-up. But in conservative group, almost 1/3 of all patients worsened. So there are a bunch of debatable questions I would like to discuss with you. For example, who are the candidates for the surgery? Should we operate after the first hemorrhage? Should we operate after the second hemorrhage? Is it important how close the cavernoma is to the pile surface? How severe is neurological deficit? Is it progressing or it is reducing? Then the very important question is when to operate. Should we operate at the acute stage of hemorrhage, or subacute stage, or chronic stage? And which method is an appropriate one for the surgery? Two-point method, which was described by Spessler group. What about safe entry zones, and what modalities, what intraoperative modalities should we use during the surgery? So the very important point is proximity to the pile surface. Then the lesion reaches the surface, and there is one hemorrhage. There was one hemorrhage. In this case, we can offer the operation for such a patient. I will show you just a beginning. Oh, sorry. I'll go back. Beginning of the video. You see the cavernoma of the brainstem, which is, I would say, exophytic. Yeah. In this case, after the first hemorrhage, we can operate this patient. Unfortunately, this patient, he came from, he attended to our hospital from other region of Ukraine, and this patient, it was a lady, she had 5 hemorrhages before she was operated in our hospital. But if the lesion reaches the surface, we can, after the first hemorrhage, we can offer the surgery for this patient. I have to say that you see these 2 slides, 2 images, and I have to mention that we should do T1 image with the contrast, because if you see if we do T2, this as you see here, this is the same patient. You see that this ferromagnetic properties of the hemosiderin ring can provide a false sense of proximity to the surface. But then they do C1, we see that there is a piece of normal brain between surface and the cavernoma itself. So what to do if there is a deep location in the brainstem? Should we operate? Yeah, it's risky. It's definitely risky. What should we rely on? We should rely on some additional information. We need some additional information. For example, it should be a neuronavigation, which is not useful always because of the brain shift, and the tractography, as you see here. Then we should be aware of safe entry zones. But I have to say that these safe entry zones, they were described to approach deep lesions of the brainstem. And these are the areas where you supposedly could access cavernoma easily. And you think, if I enter here, I will be absolutely safe. But in fact, I have to say that lesion, I mean cavernoma after the bleeding, often distorts the anatomy, and we have to use other tools, best of which nowadays is intraoperative monitoring. So I always do brainstem surgery, and in particular brainstem cavernoma removal, with the monitoring and mapping during the operation. Because as I will show you on my videos, you don't see the anatomy, the normal anatomy of the brainstem, and you hardly recognize this supracollicular and infracollicular triangle, for example, which are really the safe entry zones for the brainstem, because the brainstem is swelled and you don't see any fissures, any anatomical landmarks. What about neurological deficit? If the neurological deficit resolves after the first hemorrhage and the cavernoma is located deeply, usually I don't operate. But I always discuss it with the relatives and with the patient, because I have to mention them and to inform them that there is a possibility of second bleeding, which can be in 4, 3, even 2 nearest years. If there is a first hemorrhage, and as I showed before, the cavernoma is close to the surface, we should operate this. We usually operate these patients in our clinic. And after the second hemorrhage, we operate always the patients, but explaining them all the possible complications. If there is a progressive neurological deficit, yes, we should operate this patient. Concerning the timing, I have to say that the best time for surgery is so-called subacute phase of after the hemorrhage. What does it mean? That means that the best time for surgery is third up to 6 weeks after the bleeding. Low risk of early rebleeding doesn't require an early intervention. It's not like with aneurysm, arterial aneurysms of the brain. Then we have to operate in the first days after the hemorrhage because the risk of the re-hemorrhage is the highest during these first days. Unlike this situation, in cavernomas, we can operate in subacute phase because brainstem cavernomas usually don't or almost never rebleed in the nearest days after the first bleeding. So the best timing is the subacute phase. At this time, hematoma is liquefied. There is a stable neurological status. There is no excessive brainstem edema, and we have more space for manipulations. Concerning the chronic phase, usually I find adhering to the gliotic perilesional tissue. For example, I did my last cavernoma yesterday, and that was the case of a patient who was from eastern part of Ukraine, and I live in the western part of Ukraine, and that patient has a hemorrhage 10 months ago, and there was a lot of gliosis surrounding the lesion. It was really difficult, a lot of clots and organized clots, and it was really difficult for me to do this surgery, but the patient is doing well, so I'm happy with this. But still, subacute phase is the best timing for surgery. You see the very good work from Spessler groups. They made an analysis of impact of timing, and they approved that subacute phase is the best timing for surgery for brainstem removal. Concerning the choice of approach, we should do different approaches depending on the location of the cavernomas. For example, if cavernoma is located on the ventral or adjacent to the ventral part of the midbrain, we use pterional approach. Then if it is lateralized in midbrain, I use subtemporal approach. Then sometimes you use petrosal approach, retrosigmoid approach, supracerebral or infratentorial approach for such a cases as I am showing on that slide. Midline suboccipital approach, usually for cavernomas which are on the midline of the fourth ventricle, and far lateral approach or retrosigmoid approach or far lateral approach. Then the cavernoma is very close to the foramen magnum, not far than 1 centimeter upper. How to plan the surgical approaches? I suppose that almost or all of you aware of so-called two-point method, which was proposed by Doctors Alba and Spessler. And this is an excellent method. What is the idea of this method? You put the 1 point to the center of the cavernoma, and another point to the edge of cavernoma, to the border of cavernoma, which is the most adjacent to the brain surface, to the brainstem surface. And then you put the line and then you have the idea how to approach this cavernoma. I have to say that this is an excellent method for deciding which type of craniotomy to use, but only craniotomy. Of course, the goal of the resection is total resection. And I showed you before the safe entry zones, but as I told, we should rely on intraoperative neurophysiological monitoring because these safe entry zones usually we cannot identify. And there are some very important moments during the surgery. Usually we see, or very often we see the developmental venous anomaly, DVA. This is a vein which drains the normal brain also. So don't touch, don't remove, don't coagulate this DVA. Never do this. I will show you on video. And of course, removing the brainstem cavernoma, we don't remove the hemosiderin because hemosiderin stained tissue is a normal tissue. So we take it as a normal functioning tissue. So unlike during the removal of supratentorial cavernomas, where we try to remove this hemosiderin around the cavernoma because it's a cause of epilepsy, of seizures. In this case, this hemosiderin is stained tissue, is a normal tissue, so we don't remove this tissue. Of course, the most common site for cavernomas is the pons. And as you see this, and you know that this structure has a lot of different nuclei and a lot of different tracts. And this dorsal midline approach to the pons through the floor of the fourth ventricle are fraught with increased patient morbidity due to the injury mainly of medial lemniscus fasciculus, which is a tract which involved in the coordination of the eye movement, especially lateral gaze system. And of course, abducens nuclei and facial nerve nuclei. And as it was very nicely showed by a group of Zurich neurosurgeons, as you see, then they did the mapping of the nuclei of the facial nerve. They found the variability of facial nerve response areas in the floor of the fourth ventricle, and sometimes even these nuclei were overlapped. This is a result of their work. So this is one of the cases, a lady with a hemorrhage, and she had a mild hemiparesis after the first hemorrhage, and neurological deficit resolved in 1 month, and there was a second hemorrhage in 2 months. She admitted with a Glasgow Coma Scale 12 in poor state, and I did the surgery in subacute phase of hemorrhage on the 4th week, and you see that I removed this cavernoma, although it was deeply seated. I removed it completely, and she works as an office worker now, and she's doing well. She has children, and she's completely cured. This is another case, a female, 13 years old, 5 weeks after the hemorrhage. She had a moderate right-sided hemiparesis, and she had a left facial nerve pulse. As you see, again, this cavernoma was, I would say, deeply seated, but then we discussed with her parents the possibility of observation. They asked us to do the surgery after the first rebleeding. Then I informed them about the possibility of second bleeding. and I decided to do the surgery in this case. And I will show the full surgery. At the beginning, I will do it very fastly. You see this is not very interesting. This is a dural opening, of course. Midline suboccipital approach. And here you see the medulla and tonsils. And then I did a talovelar approach. Here you see the obex, choroid plexus. Doing the talovelar approach. And you see some discoloration of the brainstem. And I always begin with the stimulation, with the mapping of the nuclei. Just to define, there is the nuclei of the 7th nerve. And it will also define the place of the 6th nerve nuclei. This is a facial nerve nucleus. And now I can make a decision, an incision about this nucleus. As I told you before, and as you see here, there is a distortion of the anatomy of the brainstem, and we don't see these normal landmarks of the brainstem. There was a cavernoma there. Usually we see it as it is seen as a reddish tissue, and I begin to dissect it from the normal tissue. You see that this incision is very small. The blood clot is drained first, and this is the advantage of the operating in the subacute phase. You see some clots. You can do the removal of this cavernoma in piecemeal resection, or you can remove it with one piece. It's always better to remove it with one piece. You see that I don't use retractors. I use retraction with the instrument, so-called dynamic retraction. The advantage is you are retracting only then you really need to inspect one or two angles of to see something. It is one of the ways to create the additional space. For example, you use the suction and as a retractor and the suction. And you see that I am doing these sweeping movements to dissect cavernoma from the normal tissue. Cavernoma has a blood supply, and there is some bleeding always. Usually this bleeding is venous. And as I told you before, veins which drain normal brain tissue, they can be really very large, forming DVAs, as you see there on the upper part of the screen. You see the big vein. Don't touch it. And but small veins or small arterioles entering or leaving the cavernoma may be cut. Usually, or I almost never use the coagulation during the brainstem cavernoma removal. You have to spend some time looking at the cavity, removing and pulling out all the pieces looking like remnants of cavernoma, because if you leave some remnants of the cavernoma, there will be rebleeding. And as I told you, we don't touch and we don't remove the hemosiderin loaded tissue because it should be considered as a functional tissue. I see that I put a piece of Surgicel there, but usually I wait for 3-4 minutes and I always remove it back. I never leave it there in the brainstem, in this brainstem, after the removal of the in the brainstem, after the removal of the brainstem cover now, and of course hemostasis. This is the patient, and you see that 3 months later after the operation, she's almost without neurological deficit. Of course, we got a patient consent. Although during the first post-operative days, she had a moderate hemiparesis and left abducens nerve palsy. So she is doing well. So operating subacute phase of hemorrhage, always go for total removal. Leave the hemosiderin ring, do not remove associated DVA, and always use intraoperative neurophysiological monitoring, because you're getting always the information from your colleague, neurophysiologist, which navigates you to operate or to stop or be more careful. And that's very, very important. Very short video of another case. That was a patient, 58 years old, with 2 hemorrhages, left-sided hemiparesis and right-sided facial paralysis. And you see the operation, and you see that I do the mapping before, and then we use somatosensory evoked potentials, and we use mapping. And I always hear my neurophysiologist, who gives me an information about the situation, and I know how can I act. You see, I am removing the cavernoma from the brainstem. This is a post-operative pictures in first post-operative day, and then the patient. She is doing well. And then another case, but I will skip the video just because of shortage of time, and this pre- and post-operative pictures. Patient is doing well. So to finish, this is my actually our experience of our clinic too, of our surgeons. We do these procedures. At the end of the 2020, it was 32 patients with brainstem cavernomas. Now we have 35 patients, and the most common site is the pons. The female-male ratio is 1:1, and mean age is 30 years old. We used different approaches, surgical approaches, as I mentioned before, and this is a long-term follow-up. And you see that more than 2/3 of the patients improved. And just one patient died, and it was our first patient, and unfortunately he died from not surgical reasons. And less than 30% of the patients are the same, just 2 of them are worse. As a complication, I can show you the case of one of the patients, and you see the cavernoma here in the ventral, close to ventral surface of the midbrain. And during this surgery, you can damage so-called Guillain-Barré triangle. And then, as you see, this patient has a Holmes palsy, and we published with a group of very famous American and European colleagues these complications. This patient had a very severe hemiparesis, almost hemiplegia, left-sided, sorry, and also ptosis. And after the operation, he has this Holmes tremor, which is a possible complication we have such two of such patients, and this big group of the surgeons, we get that our other complications which concern this Holmes tremor as one of the possible complications. So I have to say that this midbrain location is really one of the most dangerous. There is a very nice international Delphi consensus, which was published in October 20 this year, just less than 1 month before, and you can read it, and it is very, very useful for forming the ideas about how to treat these patients. So in conclusion, surgery for brainstem cavernomas require a proper selection of patients, and it will be done, it should be done, it can be done with good long-term results. And of course, we have to use intraoperative monitoring, which helps to reduce the rate of post-operative complications. Thank you very much for your attention.
Thank you very much, Professor Smolanka, for this very interesting talk. We enjoyed your presentation, and I'm impressed by the results of your operations, actually. And I'd like to thank you one more time, because we understand your busy schedule as president of one of the most important universities in Ukraine. I know that you were just in a meeting with the Minister of Higher Education and Minister of Affairs, and in spite of all these responsibilities, you insisted and come to this to contribute to this webinar and to share your experience with all of us. Thank you very much. Now,
thank you.
Thank you. And now we proceed to our next speaker, Dr. Andriy Huk. Dr. Andriy Huk is former secretary of the Ukrainian Association of Neurosurgeons. I think Orest, I couldn't see.
Orest just arrived, and may I pass, because we are working from one computer, I will share.
Oh, he was you? Okay.
Yes,
thank you, because I was looking, I couldn't see him among the panel.
Yeah, he's from my computer. He will present from my computer.
And so he present the next speaker. Okay.
Yeah, please and I will. Yeah. Yes, and could you please let me share my screen? Could you please share my? Let me share my screen.
And you are allowed to share.
Yeah. Okay. Thank you very much. Yeah.
Thank you.
Here we are. So, and let me introduce again one of the brilliant neurosurgeon of Ukraine, and my friend and my deputy in our department. So with I think very interesting presentation. Yeah, please welcome Orest.
Good morning to everyone. I'm very pleased to take part in this webinar, and thank you. Can you hear me well? Yeah.
Yes, it's very good.
It's very good. Yeah. So thank you so much to all the organizers, for giving this possibility. We are presenting here our experience in skull base surgery, particularly that part involving the anterior skull base. Mostly you will see the first, I would like to present the pathology we are dealing with. This is mostly intra-extracranial pathology, though intracranial would be as well. And here the histology presented. Mostly, of course, it is cancers, different types of differentiation, osteoblastoclastomas, squamous cell carcinomas, differentiated, non-differentiated intra-extracranial extension, or just epidural extension. Actually, I will just mention while having this picture, not always epidural cancers grow into subdural space, as showed our investigations. Only 40% cancers would have intracranial or dural adhesions. Most of them would stay, especially those differentiated ones, most of them would stay epidurally, thus making things easier for a neurosurgeon. Another esthesioneuroblastoma quite oftenly taking part in our practice, hemangiopericetomas, intra-extracranial extension. Of course, you understand all of them would be big size because nasal cavity is big. And once the tumor fills up the nasal cavity, paranasal sinuses, then it would extend into the anterior skull base. And yet, even at that part, it's still clinically silent because of frontal lobes. And it is in the majority of cases that we have patients presenting tumors like that. So they are still walking and having just headaches. Benign pathology, juvenile GNA, angiofibromas, juvenile nasopharyngeal angiofibromas, very interesting pathology. And we are talking about those intracranial ones. And sometimes they might have intracranial extension, very rare, but they are very, very peculiar tumors taking into view their vascularity. In the past, we did in two surgical teams, a neurosurgeon dealing, as you can see, with bifrontal procedure, and that's what the exposure we have once we have bifrontal procedure. You see the anterior fossa just in the midline destroyed by the tumor, and the tumor coming up showing its head to a neurosurgeon. And another team, an ENT surgeons, they would do lateral rhinotomy. But now we changed our policy, not now, but quite a while ago, we changed our policy and we do it just with neurosurgical team. All the procedure would be done via transbasal approach de-Roumet, just by neurosurgical team. And that work which needs to be done at the skull base, at the nasal cavity, paranasal sinus would be done by neurosurgeon as well from the transbasal approach. This is the approach one of them that we employed in our practice, a transbasal approach de-Roumet that would have bifrontal flap, supraorbital flap, so two flaps stage by stage removed, thus having very excellent exposure. You see it at the upper right corner, and the orbitals very well exposed. The upper side, middle side, sometimes if needed, we might do temporal lateral exposure, lateral orbital exposure as well to move orbital to the side for big tumors to have better hole to move the tumor through. And one of this is actually a giant juvenile GNA tumor, angiofibroma, removed immune block. You know, the point with these tumors is that you cannot do piecemeal removal for angiofibromas because they bleed so hard. It's impossible to cope with this bleeding unless you do one block removal. Therefore, very wide exposure is required to remove these challenging tumors. That was done in this case. Another case, neuroendocrine carcinoma, transbasal approach de-Roumet, the same, bifrontal flap, supraorbital flap, intra-extracranial exposure, no matter how much it went into the paranasal sinus, hymeropatho sinus, intracranial extension, intraorbital extension is the site. Yet you see post-op view, the tumor is totally removed from this approach, the most important, and you can see the frontal lobes is not actually damaged at all. That's because mostly tumor removal would be done from the front. Once doing the Roumet approach, we thought we might minimize the surgery, particularly because department called minimally invasive endoscopic and craniofacial neurosurgery. By this, we imply minimally invasive neurosurgery. So we thought, why not implying something smaller? And we started to do via frontal sinus exposure, what we call subcranial approach, subcranial surgery. We do anterior wall resection, then we do, of course, replacement for aesthetic view. And the posterior frontal wall would be removed. thus exposing the anterior skull base underneath the frontal lobe, not damaging them at all, and yet having exposure, having exposure both intracranial part as well as extracranial. That's why I mentioned at the beginning that it's possible for neurosurgeon to remove both sides of the tumor, that facing the brain and that facing the nasal cavity and paranasal sinuses. This one skin incision. This is eyebrow incision. We use in order to I'll try and skip it. Harvesting the periosteum flap, and this is very briefly. I'll try to the beginning. Periosteal flap, very important for closure. I'll talk about it later, and as well as in two hands from the nasal cavity as well. So minimizing the approach from above, we added. This is what the view you will have from the subcranial approach. And periosteal, the very end of the surgery, periosteal flap placed into the side, and endoscopical view would just check it, the position. That's what you see after you finish intracranial exposure and the middle anterior skull base removed. Type of scan incision done and type of tumors we deal with, and the subcranial exposure, just the frontal sinus, no convex frontal lobe removed. Again, skin incision, eyebrow incision, harvesting the periosteum from the frontal side. That's what you see in 3 months and 6 months, no any aesthetic view. Damaged, it's well accepted by patients. Probably at the beginning, 1-2 months, it's not very nice, a bit reddish, but becoming whitish after that. And that we see after subcranial spot. That's all we need in order to remove those type of tumors you saw. So we started with bifrontal, then we moved to derma, then we moved to subcranial procedure. And what we concluded that we can remove the same tumors, but with smaller and smaller procedures. All which is needed just anterior frontal sinus wall resected, then replaced, titanium screws fixed. What in case the frontal sinus is not large enough, what we did, we'll see it later. I'll show it later. We do extension or modification of the subcranial approach. We oscillating saw, we direct oscillating saw into between the cortical plates of the bone into the sponges bone, thus separating two cortical bones, and this thus laterally extending the exposure. We will show it later on. This is wall is needed, anterior wall, together with the upper eyebrow margin and the oscillating saw. This very briefly showing that was quite large frontal sinus, which was easier, but again, it doesn't matter, it might be smaller, it would take longer. Then in case of, in order to go through sponges bone. Another video to show very briefly. I will speed it up in case needed to show the exposure, eyebrow incision, and then harvesting the periosteal flap. And oscillating saw. It might go through the frontal sinus, it might go through the sponges bone in to between the two cortical plates. Most important is direction you do in order to avoid any brain damage. the posterior wall would be just resected. But actually, presently, what we started to do, we present the posterior wall, we cut it with osteotome and with craniotomy, and then we place it in order to fill up the body defect into the midline anterior skull base after the tumor is resected. Basically, reconstructed the entire anterior skull base. This is the view opened. You can see the nasal cavity from the subcranial approach, and the frontal lobes, just far underneath the frontal lobes, no damage to the cortex done in this case. Another brief video in order to show the procedure. This is the anterior wall removed already, and you have the posterior wall preserved. And you see in this case, what is very important to see, this is the frontal sinus itself, and this is the oscillatory saw went through the sponges and cortical plates. You see, there was no frontal here. And now at this stage, I'll just briefly here, and all of this is like new posterior wall of the frontal sinus created. Therefore, together with the natural posterior wall of the frontal sinus, it's here. This created. This would be the entering into the skull base. And that's what we have after that. Quite wide exposure. You have frontal lobes. You have planum sphenoidale, upper wall of the orbit and nasal cavity. Now we have some of the pathology. If I have some more time with videos, it might repeat. Probably I'll skip it, it mostly repeat. This is interesting in a way that we have endoscopic view. Just after the tumor and plastics done, we just check it out with endoscopy and the nasal approach. That's how the substitution material looks like, periosteal flap, after the finishing surgery. Actually, it is not fixed. It's just fixed with balloon catheters in order to support the entire construction. This is you saw the pre-op at the just a few slides before, and now post-op slide. Some of the statistics, of course, as it is expected, most of the pathology would be malignant, up to 78, up to 80%. Most of them would be cancers, as well as adenocarcinomas, esthesioneuroblastoma, osteoblastoclastomas, quite rare, together with chondrosarcomas. Among benign pathology, osteomas and meningiomas would be most prevalent. Origin of this extracranial tumor origin with further intercranial extension. Of course, as expected, ethmoid sinus line on the outer surface of the skull base would be most responsible for these tumors. Then we decided why not applying this kind of approaches, dermare or subcranial surgery for benign pathology like midline meningiomas, rhino-olfactorium meningiomas. Also even there, quite large, but still there in the midline, well vascularized. Why not reaching them via subcranial procedure, via frontal sinus? That's what was done in this case, and post-op, it's very clear, no damage done to frontal lobes, not even edema or whatever, and because of direction of tumor attack would be just straightforward. Again, benign pathology, rhinofactor meningioma, transbasal approach, and subcranial approach. Then we compared, would there be any difference in between post-op complications, patient's conditions, MRI showings, and so on. The exposure for dermal or bifrontal, wherever, and subcranial. And the result will be the same. Very little frontal lobe damage and totally tumor removed. Then we compare this kind of approaches for malignant pathology. Transbasal, bifrontal approach, subcranial approach via frontal sinus, just I'll repeat. And again, all of them are large tumors because patients come too late for obvious reasons. And but on and off, the pathology would be the same signs, the same histology. So we compared what would be post-op in view of their complications and results. Again, on MRI CTs, we have exposures and we have the results. Would be the same, either big approach or small approach. Of course, complications, as at the end of the day, when we counted the complications, we had twice less with subcranial approach. It is less convenient in view of manipulations, of course, because it's smaller, but yet it's possible. It might be challenging, but it's possible, and the results would be twice less complications in comparison with those larger exposures. Some of the cases pre-op, post-op to show that even lateral exposure would not be contraindications for midline approach. Even lateral exposure still achievable in this case. One of the video, very briefly, just pay your attention at the plane you gain when doing this approach. This is the anterior skull base. Basically, a patient's just looking parallel to the anterior skull base. Frontal lobe would be somewhere there. And the neurosurgeon would just walk in between the anterior skull base and the tumor itself. I will just briefly skip it, as the whole idea was to show the exposure we have and some benign pathology, planum sphenoidale. Different variety of approaches can be used for this, lateral supraorbital approach, pterional approach, wherever, bifrontal approach in the past many patients used. In this case, we use subcranial approach. Taking into view that it goes slightly into renal refractorium groove, thus making things easier for us to pick the tumor out of this hole, as the rest of the approaches would rather direct at this point than at this point. And you see post-op CTs, no tumor and no frontal lobe damage. This is the view we have. This is the case I just showed. And frontal lobes well exposed, just trying to skip. Walking through interhemispheric on one side and a very, very basic direction too. Again, this is the plane, anterior skull base plane we have. Basically staying parallel to the anterior skull base. So the whole idea is to show the view we have and anterior skull base, the angle we walk in regard to this. Trying to the very end. And the view afterwards. And some of the statistic midline defects after surgery. This in centimeters we have midline bone defects, midline extended, midline trilateral. Do you have still time? Shorter. Yeah, so the defects are quite large, and it's very important to close up these defects. It's another part of the surgery as much important as the tumor removal. And these are some of the complications we have with the large anterior skull base. You see brain prolapse. It might happen when we have brain edema or meningitis. Then we have this kind of pathology, prolapsing into the nasal cavity, thus making plastic material, substitution material inadequate. But that was in the past. Now we're trying to make it thicker, anterior skull base substitution material, and placing the posterior wall of the frontal sinus here into this defect, thus preventing this complication. When the defect is too large, when the orbit excitation done, we have again brain prolapse, but with no complication. You just move down because the hole is too big. But yet, as months pass by, it comes, as you see, it retracts back because of after brain atrophy, brain edema disappeared, whatever. It comes into normal. So in this case, we just waited and saw, wait and see. And dural closure, again, this view we already saw. That's endoscopic view of the substitution material, periosteal flap, how it looks like from the end, from the nasal cavity, and the material we use for dural closure and for anterior skull base closure. Mostly it is periosteum pedicle flap. In the majority of cases, it is enough, it's adequate, and it is enough in most of with our procedures. And free material, we have come to the point of view that it's not good. It's all the material should be pedicled. And it's only for dural closure, we use free material, it's mostly facial lateral or periosteum, or even artificial material. Some of the complications in the intra-extracranial surgery we have from the publishing, the mortality, it might be quite high, as well as overall complications, quite high. And in our case, we have no mortality at all. We had CSF fistula. It's one of the challenging cases, as in many cases, it would follow with meningoencephalitis. I think I will finish by now. Thank you so much for listening to me, to our presentation, to our work. Thank you so much. And I'll handle it on to Andrei Guk.
Thank you so much. I think so. We are out of time, but we will speed up the process. And Nasser, please.
I think
I will
now I will introduce Dr. Andrei Hook. He is going to be our next speaker. We have many questions over the chat, but now we make panel discussion after Dr. Andrei Hook talk.
Yeah.
Now it gives me great pleasure to introduce Dr. Andrei Hook. He's going to speak about extended endoscopic endonasal approaches to skull base tumors.
Okay. And let me open my presentation. 1 minute. Yeah. Yeah, here we are. Dear friends, dear colleagues, now it's okay?
Yes, it's okay.
Again, thank you so much for this very good webinar that really allows us to see how we can use up-to-date techniques in neurosurgery to move forward with, again, it's my humble opinion that it's not depends on the countries, it depends on people. And I'm very glad that I see people who really like neurosurgery and work as neurosurgeons. And I know that not only neurosurgeons see our part of our webinar. We are working for our patients, and that's why I would like to. I will shorten my my presentation just to make key points that we, from our experience, head of department of endoscopic and craniofacial surgery in Ramadan Neurosurgery Institute, and again through the last 15 years, we do our best to introduce many invasive techniques in neurosurgery in Ukraine and especially in our institute. So today we will talk about the possible extended endoscopic approaches, transethmoidal, transpterygoidal, transmaxillary approaches. And I would stress the issue that you see in that slide, the petroclival hardoma with a huge extension. And of course, we can do the frontotemporal craniotomy, we can do subtemporal approaches, but we also do extended endonasal transfonoidal approach, and I will show you. So of course, the anatomy, I will not take more attention on that, but without knowing anatomy, we cannot achieve the results that we can do through many invasive surgery. You see, it's thanks Ariel Kane, that's very good was publications refining the anatomic boundaries on the endoscopic endonasal transpterygoid approaches, and you can see that how we can easily identify our surgical theater to avoid damages and to really be specific for our surgery. So how it looks like intraoperative. Again, I will not take more. You see drilling. You see the real anatomy. Again, very good knowing of anatomy allows us to avoid damaging of vessels and nerves. And of course, step by step, it's not from our experience from the very beginning, of course, the duration of surgery becoming longer with endoscopic surgery, but after 20-25 operations, we really can speed up and doing that, if we will compare with microsurgery, at the same time, even less time. You can see the pre-operation and post-operation MRIs, and you see that we, after 3 years, no recurrence. Also, this you see female, 45 years old, pterygopalatina fossa schwannoma with subtemporal fossa and intracranial extension. You see. And again, so subtemporal approaches, transmaxillary approach, or EAT approach, extended. And of course, for that, we have everything to do that through transpterygoidal transmaxillary approaches. And you see how anatomy knowing allows us to really manage this tumor. Again, short video. You see the clear boundaries, clear orienters. I will speed up a little bit. You see pre-op and post-op. Also, I will show you pituitary macroadenoma, NOSP4 with cavernous sinus extension. And again, you see the anatomy, so very clear and very specific, that really allows us to do our best and to manage this case. You see the different stages of operations, and you see that in the end we making the revision of cavernous sinus, and okay, it's plastics regular. You see at pre-op and post-op. Again, another case that it's again giant pituitary adenoma with NOSP4 extension. Of course, microsurgical transnasal approach. Of course, we can do EAT approach, and you can see how we do it. You see pre-op and post-op. And what about the results? So in our 41 cases so far, so you see that initial localization was pterygopalatine fossa, sphenoid sinus, petroclival junction, sella turcica, and you see the pattern morphology from cancer, angiofibroma, hemangioperitoma, paraganglioma, neurolymoma, neurofibroma, fibrous dysplasia, fibroangioma, osteoma, esthesionoblastoma, chordoma, and pituitary adenoma. And what we achieved, the gross total resection 21, it's more than 50% of our patients, subtotal resection 11, partial removal 8, it's around 20, and biopsy only 1 case. So our complications, CSF leak in 1 case, diabetes in 2 cases, hemiparesis in 1 case, and we don't have any post-operative mortality. So what is our conclusions? That EAT transethmoidal approach is sufficient for tumor exposed in cases of infraparacellary tumor extension. Transpterygoidal EAT approach is effective in cases for tumors with lateral extension, middle fossa, pterygopalatine fossa. It is advisable to use the EAT transpterygoidal transmaxillary approach for tumors with significant lateral extension, and extended EAT approaches allows us to achieve low rate of postoperative complications in tumors with paracellary extension in comparison. So we have less than 10% with comparing to other researchers from 8 to 15. Thank you very much for your attention. Nasser? Okay, Nasser not available now. And let's move to our discussion. I think that now we can do our best and to hear comments from the floor. Yeah, please. Nasser, can you hear us? Okay, we have questions from Uday Gupta from India. How big tumors can be removed endoscopically? So it depends of the localization of the tumor, and as we show you that we can do that not only endoscopically but also combined methods if it needed, and it's again, it depends individually from the localization and also from what how big is tumor. But you see that in our experience, even tumors, giant adenoma and angiofibroma can be removed, also used fully endoscopically or combined method with neurosurgery, with microsurgery. How you separate bone from vasculars, internal carotids? What techniques you use at the cavernosus sinus? Orest, could you please answer how we separate bone from vasculars and internal carotid, and what techniques we use at cavernosus sinus? How you separate bone from vasculars, internal carotid, and what is techniques you use at cavernosus sinus? Could you please?
Just speaking, or right?
Yeah, just speaking. Just speaking.
In case we have malignant,
Yeah, please have a seat. Please have a seat.
In case we have malignant procedure, we would not do any separation because malignant tumors. In case of malignant tumors, there was no dissection done in regard of cavernous sinus invasion. Why? Because as we know that cancers, they they have invasive character and they invade adventitia. But as I saw at the beginning, as we saw that some up to 40% cancers, or even more than that, they do not have invasive character, and they would rather enlarge in size, shifting the artery, not invading the artery itself. Basically, we use the same procedures, the same techniques as for meningioma surgery. It's the situation inside the operation when we need to decide if the tumor invasive or not only cancers invasive. At cavernous sinus, it depends on the tumor itself. If you are talking about meningioma cases, then we just open the cavernous sinus, meningioma, schwannoma, or fibroma cases, then we just and we work transcranially. We just open the cavernous sinus from the unusual trigonums, by Dollins, wherever. It depends on the tumor, where the spread of the tumor. If you are talking, probably you are talking about extradural approaches, endonasal approaches, or subcranial approach. In this case, what is for cavernous sinus? Again, it depends on the tumor. If it is fibroma, quite often taking place in extracranial surgery. fibroma or sometimes schwannoma, then we will just separate from the cavernous sinus. Either the walls of the cavernous sinus destroyed by the tumor, or we do drilling in order to expose the cavernous sinus. It all depends on the current, malignant, not malignant, what kind of malignancy. That's all.
Okay, thank you. Thank you. Any other questions, dear colleagues? Okay, so
I think, Andriy, we have questions over the panel.
yeah, please, because we already started to answer to questions from Uday Gupta regarding how big tumors can be removed endoscopically. It's I answered the question, and how we separate bone from vasculature.
Okay, okay. And so I think somebody was raising hand too.
Yeah, please.
Just let me check if anyone would like to speak or to share in the discussion. Please go ahead. You will be allowed to speak now.
And maybe in the end we can back to skull-based surgery questions, because I do believe that majority of our participants will attend two parts of our webinar,
okay.
skull-based,
Okay.
and me personally also, of course, and my friends. Okay.
So do you like to open discussion now among the panel concerning skull-based surgery, the first session, or to make it at the end of the webinar?
I think that we can make it in the end of the webinar, and also because if we little bit out of time, we can move to second section, and of course questions can be done through the questions chat.
I think Andrew, it's better to answer questions during discussion so that everyone is going to get some benefit from your explanations.
Okay.
And so if you like to move now to the second session and to introduce the next speaker, it will be great.
Yes, so far I see only two speakers. I don't see Professor Yakov Fishenko. That's why we moved, as it was scheduled, to Yuri Lankovsky, who represents also Ukrainian neurosurgery, and he will talk about radiofrequency nucleoplasty on cervical and lumbar herniations using Cosman electrode method. Yes, please, Yuri.
Hello.
Yeah, we can hear you. Yeah.
Mr. Do you hear me? Yeah.
Yep.
Okay.
Okay, can you share your screen?
Yes. I try it now. Can you see my screen?
No, not yet.
Once again.
Just use
Yes, I see the green button. Yeah.
Yeah, green button. Yeah, demonstrate you. Nasser, could you allow Yuri to demonstrate?
He's allowed to share screen. Yes, he's allowed.
Okay, let's do it, Yuri.
Yes,
just
I do. I press button, but I don't see any.
Green button. Demonstrate.
Yes, I press it. Yes.
And press it.
Press, but nothing will happen.
Okay, I will tell you, Uri, did you open the PowerPoint?
Yes, everything opened.
Okay, minimize the PowerPoint, then double click over the green button at the bottom 2 times by the left hand. Yes,
Okay.
now it's good.
Yeah,
Now
here we
it's
are.
good.
Yeah,
Yes.
but for full screen, yeah, to make it for full screen.
Okay.
No, it's not full.
Okay, try once again.
And
Yes. Okay. Can
That's
you see?
good. Yes, that's
yeah,
good.
yeah, good.
Okay. Thank you so much for your helping. I'd like to say many word of thanks to Professor Mr. El-Ghandour for invitation for this great meeting. We were met with him 2 years ago, and we have had a very pleasure meeting. Thank you so much for meeting, for inviting me, and
Thank you.
Thank you. So thank you so much. It's a sad story. That's why it's not possible to meet face to face, but I think in future we'll check it problem. Okay, and about my presentation. My presentation is based on a practice of Medical Center of Medlon, which is situated in Kamyanets-Podilsky city. The main aim of our center is performing mini-invasive endoscopic, laser, and another mini-invasive surgery, and that's why we have small experience in this field. And we will talk about our experience of our center in radiofrequency nucleoplastic using Cosmo-Flex rod, lumbar, and cervical spine cavitation. Let's start. I don't see any. Chronic low, I don't see a full screen. I'm sorry. I need to close. The screen is shut me all my.
You can it's through the
I want
button.
to shut a window with video. I don't know how to do it.
What do you mean?
Okay, chronic lumbar pain is a common clinical condition which have very severe medical, social, economic, and treatment difficulties. Chronic treatment knowledge of modern therapy, pain treatment knowledge. I'm sorry, I don't see full screen of my.
Yuri, you can do that.
Okay.
Through.
Okay, that's right.
Yeah.
Okay, I'm sorry.
Okay.
Chronic lumbar pain is a common clinical condition causing medical, social, economic, and treatment difficulties. Chronic pain treatment requires knowledge of modern diagnostic and therapeutic approach. What kind of treatment we have to choose? It's a question. Maybe we can use drugs, maybe medication, maybe chiropractic, maybe surgery. What is the question? It depends on many factors. The first of all, it depends on hernia location and size, existing of radiculopathy or myelopathy, the term and result of conservative treatment, and of course, the skill of physician. But the most of all, it depends on opinions and wishes of patient. That's why we try to find the most mini-invasive and resulting method. Volumetric reduction of nucleus pulposus has been achieved using various methods such as hemonucleolysis, percutaneous laser discectomy, and percutaneous discectomy. Radiofrequency thermocoagulation nucleoplasty is the minimally invasive percutaneous intradiscal treatment method that could be preferred in the treatment of radicular pain caused by disc herniation. Radiofrequency nucleoplasty is performed using a transmitter device called coablation technology based on transmission of radiofrequency energy. The core tissue of the disc is specially destroyed with radiofrequency energy. The energy particle have the potency to lease the soft part of the disc tissue to molecules. It works at relatively low temperature, between 40 and 80 degrees of Celsius, preventing the damage in the surrounding tissue. A total of 1 milliliter of nucleus tissue is evaporated, which decreases the volume of disc tissue. Reduction of nucleus pulposus and decrease in pressure cause elimination of pain. In our practice, we use monopolar technique with Kosman-Flickström technology. There are two different methods of monopolar nucleoplasty. The first one is by using Kosman-Flickström. The second one is EDAT technology. They are very similar, but the way of insertion of the needle is different. In first case, insertion of needle we will use from ipsilateral position, and in second, from contralateral insertion. Since 2016, we performed 58 radiofrequency nucleoplasty using Kosman-Flickström method. The distribution of patient was the most often was the herniation of L5, L4, L5. The second is L5, S1, and L3, L4, L2, L3 is minimal. Indication: lumbar herniation till 6 millimeters, no sequestration, no foraminal or extraforaminal location, no ossification, the term of disease till 2 months. The patient, of course, want to avoid the surgery. The technique: the most of patients were operated on an outpatient basis. Less than 5% of patients with comorbid condition were operated on in hospital. Local anesthesia with anesthesiological support, X-ray control, needful equipment, any radiofrequency generator, maybe radionics, Kosman, etc., and 6 active electrode, in that case, Kosman-Flickström. Needful equipment. We have to choose any radiofrequency generator, but today in Ukraine is the most popular old version of this generator is Radionics RFG 3C+. Of course, we can use Flickström cannula and Flickström electrode. And of course, in the world, the most popular is Kosman generator. Anatomical substantiation, or how does it work? To avoid possible damages of important anatomical structure, we have to very carefully planning our preoperative MRI images. In the first picture, you can see what the distance from the entry point to the middle line must be between 8-10 centimeters. In that case, the needle will go through the muscle massive, and damaging of peritoneal cavity is impossible. And of course, besides, we have to always think about the safety triangle of Campbell. In this case, we have very easy to avoid the damages of nerve root or dura. As I say, preoperative planning is very important to avoid damages of anatomical structure. We have to carefully evaluate MRI imaging before surgery and measure the expected depth of needle inserting and expected distance from the middle line to the point of insertion. In this case, you can see that the distance between midline and entry point between 8 and 10 centimeters. In this case, is very difficult to damage any important anatomical structure. And we can predict size of needle. In this case, size of needle is about 11 centimeters. Procedure techniques. The patient is placed in prone position on X-ray fluoroscopy table. Pseudoanalgesia is administered. The surgical site is prepared for aseptic technique, and the skin is numbed at the cannula insertion site using local anesthetic. Siam in AP position. The entry point is located laterally from the midline directly above the disk space between 8-10 centimeters, as I say. We can see a marking scheme, and the entry point is on a distance 10 centimeters from the midline, directly above the disk space L4, L5. And you can see in next pages, X-ray picture. C-arm is in oblique position on the side of the pathology. The flex rod cannula is orientated parallel to a single vertebral end plate and advanced through Campbell's triangle into the posterior disc. We must feel insufficient defense, then the tip of needle will touch annulus fibrosis. Of course, control the needle position on AP. On this picture, we can see that the tip of needle is only touch the annulus fibrosis. And control the needle on the lateral view. On this view, we can see that needle 2 must only touch the annulus fibrosis, don't penetrate it. Then we have to carefully penetrate inside the disc space. The depth of insertion is strongly depends on the location of herniation. In that case, we tried to insert the needle to the middle of the disc space. The fixed rod electrode is inserted through the cannula, so it extends out of the cannula mediolaterally into the posterior disc, proximate the prolapse. As you can see in these images, if you compare from this picture, in this picture, we insert only cannula without active electrode. Then we insert the electrode, active electrode, through the cannula. The tip of electrode is go outside the cannula, and it locate directly inside the disc space. Of course, finally checking of the needle position. We can see that active tip of electrode is strongly inside the middle of the disc space. On the lateral view, it's very important. The needle, the tip of needle may be as close to the posterior part of disc as possible. We have some problem when we have a patient with L5-S1 herniation, and this level try to be very careful. L5-S1 nucleoplasty peculiarities. The difficulties on this level depend on different size and height of crista iliaca. In case of very high crista iliaca, bone structure in oblique view shut the free way to insertion fixed rod electrode. But almost always we can find the narrow window between crista iliaca and sub, which allow us to approach the disc. On this picture, you can see that the free window in which we want to insert the needle to the disc, very, very narrow and small. But if you have experience in this field, it's not a problem to insert a needle through this window. We have some problem before the needle touch the bone structure. In this case, we have to rotate a needle and the tip of needle, in this case, change his direction, and it's very easy to penetrate the disc space. In our practice, we didn't have any problem with L5-S1, and in all cases we have a success. In this picture, you can see that L5-S1 disc space is very narrow, but needle on the AP position is touch the annulus fibrosus, and also on the lateral view. L5S1 AP position, the needle, cannula inserted into the disc. In this picture, you can see that through the cannula, inserting active electrode. And the second problem of L5S1 is in the needle position of the tip of a tip of the needle, because it's very difficult to insert the tip of the needle as close to the posterior part of disc as possible, because it depends on crystal Iliaca height. In these cases, the distance between medial midline and entry point is less than 8 centimeters. It may be 6 centimeters. In these cases, the angle of insertion of the needle is very acute, and that's why a tip of needle penetrate very close to the anterior part of disc. Procedure technique. If the patient awake, sensory and motor stimulation are applied. If any tingling sensation or motor response is evoked, including in any dermatome at or below the flextrode level, the flextrode is absolutely removed away from the spinal canal and nerve roots, and stimulation is repeated. The flextrode electrode is always removed from the cannula before reposition. Before radiofrequency is delivered, sensory and motor stimulation and lateral AP and oblique X-ray views are used to confirm that the flextrode cannula and electrode metallic active tip are fully within the disc and spaced from the spinal canal and neighboring nerves. Radiofrequency is applied to flextrode for 4 minutes using set temperature 80 degrees. Then they put 80 degrees. Some patient is feeling not good. In these cases, we have to make 70 degrees or less. The patient is continuously monitored for signs of discomfort. Following radiofrequency application, the flextrode electrode is withdrawn and ceftriaxone 0.5 milliliters, or corresponding to 75 milligrams, is injected into the disc through the electrode cannula. The cannula is withdrawn and a bandage is placed at the skin insertion site. After the procedure, the patient is observed for 1 day in the hospital, including 2 hours of bed rest. The result. We cannot consider our study as proof research. We just want to deliver our own experience in this field of pain management. We don't have a statistic sufficient evidence of our treatment, because more than 50% of patients did not visit our center after procedure. It means what may be everything good or maybe everything bad. We don't know. We don't know about 50% of patients, but we have outcomes about 24 patients. In summary, there are 24 patients who visited us in 1 month after procedure. 5 patients pointed to absolutely absent any improvement. That's why we were operated in the month. I predict what in these cases we have a contraindication of this procedure, and we did this procedure only on opinion and wishes of our patient, because they want to avoid surgery. 8 patients had sufficient improvement, but we needed to include to their treatment physiotherapeutic methods. 11 patients were happy. Cervical spine. Need full equipment. In this case, we don't use a flextrode electrode. We use simple Cosman cannula with 3 metal tip, 5 millimeters. And as active electrode, we used radionics active electrode, 50 millimeters. What is different between flextrode electrode and radionics simple active electrode? Difference in the size of the active electrode, because in this case, active electrode doesn't through outside the cannula, and cannula works as only as the free metal tip of a needle. Anatomical substantiation. In this case, when we try to treat cervical herniation, we use only anterior approach. It's very easy to perform, and if you have a small experience, you have to avoid any damages of neural structure of spinal cord. But the tip of needle must be very close to disc herniation. Indication the same, but herniation till 3 millimeters, no sequestration, no foraminal or extraforaminal location, no ossification. The time of disease till 2 months. The patient wants to avoid the surgery, of course. Procedure technique. The patient is placed on a back on X-ray fluoroscopy, sedative analgesia administered, the surgical site is prepared for aseptic technique, and the skin is numbed at the cannula insertion using local anesthetic. We have to very polite mark the operation field, and we have to draw 2 lines, one of the middle line, and second is on a projection of the arteria carotis on the neck. Checking the level on the IP position. We use 2 fingers approach. Third finger move trachea to the medial line, and the second finger try to move arteria carotis laterally. In this case, our surgical approach will be directly between 2 fingers. The needle insertion between tips of 2 fingers directly to the disc. IP and lateral CM control of the tip position. As you can see, in this case, the cannula is used as an active electrode. And after insertion active electrode inside the needle, the size of cannula doesn't change. The electrode Cosman 50 millimeters is inserted inside the needle. The method of treatment is the same: motor and sensor stimulation, then 80-degree ablation till 4 minutes. The result. We performed since 2016 year 21 patients. It was only women. We don't know why. Cervical radiofrequency nucleoplasty. 17 patients came back to the center within 3 months to give us their feedbacks. 7 patients had sufficient improvement, but they needed to include to the treatment physiotherapeutic methods. 10 patients were happy. As you can see, the result of nucleoplasty on cervical spine is better than in compared with lumbar spine. Case number 1, patient N, 38 years old, driver, low back pain, no radiculopathy, no myelopathy, was 6 point. After 2 weeks conservative treatment was 5 point. Is improvement is not good. As you can see, the discrimination of the level of L4, L5 on the lateral view, and confirming on the AP view, on the external view. After 2 years, the image on the left side is before, the image on the right side after. You can see sufficient degrees of the herniation size. After 2 years axial view, you can see sufficient degrees of size of the herniation. Case number 2, patient R, 34 years old, unemployment, severe low back pain, no radicopathy, no myelopathy, was 7 point. After 4 weeks conservative treatment, including steroid injection, only 6 point. Herniation, not very big, but patient have pain, back pain, and on axial view after 1 year. On the left side before, on the right side after. You can see also a sufficient degree of herniation. And axial view too. Very interesting case number 3. Patient K, 51 years old, major military medical orthopedist, hero of Russian-Ukrainian war, defender of Luhansk airport, low back pain, no radiculopathy, no myelopathy, 6 point. After 6 month conservative treatment, and conservative treatment include many steroid injection, hemonucleolysis, and only 1 point difference between before and after. Herniation is not very small. It's on the margin of the surgical and conservative treatment. On the lateral view, you can see it. And you can see it on the axial view. What happened after 6 months? We don't have any...
Yuri, could you please speed up?
Yes, of course. I finished. We don't have any postoperative images at any evidence about his condition, but we have these pictures. He is fishing, he is cooking, he have a rest with his friends, he's skiing, and he have a rest. But honestly, he don't have a very good improvement, and we have to do an MRI imaging. Conclusion: reticuloplasty is safe and easy procedure which sufficiently improve the patient condition in the long term. Holding on indication are required, but outcomes fully depend on non-compliance contraindication. Thank you so much for your attention. I'm sorry for first problem, and it's our clinic in Kamyanets-Podilsky. It's our colleagues. And I want to invite everyone to our best city of the world, exactly for me, because it's my homeland. It's a city of Kamyanets-Podilsky. Thank you so much.
Thank you so much, Yuri. I think that we do have questions. Yeah, please welcome to ask questions, and we will do our best in the end of our session to make a discussion. And let me introduce our next speaker, Dr. Boris Pavlov. Also, as I mentioned, today we have all brilliance of our neurosurgery, and Dr. Yuri Lankovsky. Now moving to Dr. Boris Pavlov. Yes, please. And we have a
you hear me?
Yes, we hear you, and we have very good. I can imagine that very good presentation called "Challenge Endoscopic Removal of Lumbar Disc Herniation." Please.
Sorry. Just a minute.
Yeah, please share your screen.
Do you see my screen?
We see, but we see only Zoom in your screen.
Okay. Just a minute.
Yeah, now to move to your presentation, and yeah. And
now, okay.
Yeah, it's good, but please make it for full screen.
Okay.
Yeah, about that.
So, hi, dear colleagues. For first, thanks me, dear Professor El-Ghandour, for invitation. It's a big honor for me.
Thank you.
So, yeah, today I'm going to focus on the issues of endoscopic removal of intervertebral hernias in the lumbar spine, and more specifically on the transforaminal approach for endoscopic discectomy. Let's have a small discussion into history. Mixer and Barr are rightfully considered the pioneers of the surgical treatment of disc radicular conflict. They performed open discectomy. Yasargil and Kaspar started to use a microscope to remove intervertebral disc hernias, microdiscectomy, and Kembin Hijikata developed the technique of lumbar discectomy using an arthroscope, endoscopic discectomy, PELD. Percutaneous endoscopic lumbar discectomy. The current trend in endoscopic spinal surgery was defined by Albert Delfianes from big to small, from small to big. This means a decrease in tissue trauma during the surgical approach and an increase in internal visualization for broader possibilities of direct surgical technique, instruments, optics, and other. Let me add a few words about the safe area of access to the intervertebral disc. Here is Kembin described triangular safe zone bordered by exiting root anteriorly, the traversing root medially, and the superior end plate of the lower lumbar vertebra inferiorly. It should also dwell on two options for transforaminal endoscopic access: inside out technique and outside in. In the first case, the instrument is located in the intervertebral space, and the removal of the hernia material is performed from the inside. In the second case, the working tool is located in the anterior epidural space. Thus, the outside-in technique has a number of advantages. It allows visualization of neural structures, the removal of sequesters with cranial and caudal migration. On the 3D model of the L5S1 segment, we see the point for entering the spinal canal, the apex of the superior articular process of the underlying vertebra. It should be emphasized that the initial correct positioning of the instrument is an important guarantee of the success of operation, since it's rather difficult to change the access trajectory for the transforaminal approach in the process. To this end, when installing the instrument, it's advisable to more often compare the lateral and AP view, as well as what's called keeping in the head, a 3D model of operating segment. Operation theater, the prone position of the patient with reclination of the lumbar lordosis. Operating team of 4 people, 2 technicians, anesthetist, surgeon, and nurse. C-arm endoscopic equipment, instrumental part, vital function indicators monitoring equipment as well. Some surgeons operate in the lateral position. This is a matter of habit. However, we prefer the prone position as it is more comfortable for the patient, firstly, and makes it easier to switch to the conversion technique of microdiscectomy, secondly. Anesthesia. Most surgeons perform PELD under local anesthesia and intravenous sedation. This is dictated by safety consideration to maintain verbal contact with the patient. Our patients noted very intense pain during the formation of the bone canal and removal of a large disc sequester. Having studied the experience of our colleagues, is resolving this problem. We began to use epidural anesthesia with the effect of sensory motor cleavage, preservation of motor activity in the lower extremities with adequate analgesia of the operative field and the affected spinal motion segment. This made it possible to reduce the amount of sedation and increase the comfort of the patient and the surgeon during the operation. The epidural catheter allows you to regulate the amount of anesthetic, and the patient's pain is well depicted in the photo on the right. To the question of how he feels, gesture with the left hand V victory. We shared our positive experience of the use of epidural anesthesia during transforaminal endoscopic discectomy on the pages of journal Innovative Solution in Modern Science. Preoperative planning is an important stage of work. We can say that is 1/3 of success. The direction of trajectory of the working instruments is towards the hernia, taking into account of the anatomical features, the patient's complexion, the iliac crest, migration of the sequester, etc. Proceeding from this, the median variance of hernias require a more horizontal positioning of the instrument, migration sequesters corresponding angulation in the cranial or caudal direction. Let's move to marking our operating field. Operation marking under the control of the C-arm, spinosus process in the center of the vertebral body, and plates in the form of lines. The iliac crest is noted. Point of entry for level L3, L4, 8-10 centimeter from midline, for L4, L5, 10-12 centimeter, and for L5 is 12-14 centimeter from midline. Local anesthesia with lidocaine solution. A spinal needle is placed on the superior articular process, skin incision up to 1 centimeter. As next step, the spinal needle is changed into a guide wire. Dilators are installed along it to expand the wound channel. Placement and advancement of the thumb-shitty needle through the supraarticular process into the spinal canal. The guide wires stay in place. Successively replacing each other, burrs of different diameters from 4 to 9 millimeter expand the bone canal. Now let me add a few words about drills. In 2006, Thomas Hugel and Boris Mikis from Germany offered the safest hand drill system, Maxmore Spine. Pay attention to the blunt tip of the drill. During drilling, it moves into the spinal canal, gently pushing away the neural structures that protects them from damage. Next step, positioning the dilator with working sleeve. Take special care when inserting the working sleeve. It must be installed with beveled edge towards the spinal canal to prevent damage of nerve root. Removing the dilator, introduction of the endoscope and instruments into the working sleeve. Let me say a few words about endoscope and working instruments. Endoscope characteristic in the diameter 3.7 millimeter, optics 30 degrees. Working tools, diameter 2.5 to 3.5 millimeter. Continuous irrigation of the operating field with saline to improve visualization and reduce scarring process. From this moment, the so-called endoscopic stage begins, as opposed to the previous one, radiological stage. Positioning of the instruments in the operating field, determination of anatomical landmarks, removal of disc hernia, radiculolysis, revision of the epidural space. In the photo center, you can see disc hernia in operation field, and the root partially free, spinal root full free, and you can see epidural fat. Epidural fat indicate sufficient decompression of spinal root. The beginning of the herniated disc removing, small video. As long as there is no visualization of neural structures in the operating field, the removal of the hernia should be started carefully, very carefully. From the free edge, avoiding deep immersion of the forceps, as carefully as female dog carries their puppies, grasping skin as the nape of their necks. It's good and indicative when the sequester is removed and blocked. However, this is not always possible. With large size of extruded material, the following maneuvers can help. Light rotation movement of the working sleeve, clockwise and counterclockwise. Extraction of the disc material together with the endoscope. In the second case, the operating nurse, fixes the working sleeve to prevent it from slipping out of bone canal. And now, most of the hernia has already removed. The root and epidural fat are visualized. Remnants of the hernia are removed from anterior epidural space. Sometimes with some harnesses. And now the remnants of the migrated sequesters are removed using forceps with flexible tip, special forceps with flexible tip. Spinal root is free, pulsating. The extracted hernia material is assessed. The endoscopic system with working sleeve is removed. Suture is applied to the skin up to 1 centimeter. Like every treatment method, PELT has advantages and disadvantages, alas. Advantages, high safety and efficacy, low injury rate, quick rehabilitation. And limitation, radiation exposure to the patient and staff, the need for strict primary positioning of working tool, rather expensive special equipment. and some comparatively fresh information from our colleagues. Brazilian colleagues strongly recommend PELD for the treatment of disc hernias in the lumbar spine. Chinese colleagues find PELD better than a microdiscectomy, especially in the middle and long-term period after surgery, based on 2 years meta-analysis. Radiation exposure. During surgery on the patient, according to literature data, up to 4% of the maximum permissible for a year. Surgeons are naturally more exposed to radiation. The use of protective gloves, collar, and aprons is mandatory. The total radiation dose is controlled by accumulative sensors located on the shoulder and the neck, chest area, on the protective apron and under it. Clinical case 1, patient D, male, 45 years old dentist, therapeutically resistant radicular pain within 2 months, MRI diagnosed L5 with 1 disc insertion on the left, severe pain syndrome. Was performed, PELD was performed on the liver, L5 with 1 left, verticalization after 2 hours, no radicular pain. He returned to professional duties in 10 days, MRI control, positive MRI control, you see positive dynamic. Patient P, 26 years old, realtor, therapeutically resistant radicular, severe pain for 6 months. MRI diagnosed disc hernia L5, L6, lumbarization, median extrusion. PELD was performed on this level and verticalization after 2 hours, no radicular pain, refusal of analgesics, discharged next morning, and took up her professional duties in 10 days. MRI, you see positive dynamic. Thank you, dear colleagues. I appreciate your time and attention.
Thank you very much. Thank you very much, Boris. It's really amazing. And Nasser, could you introduce our very important speaker? I can say that it's another one brilliant spinal surgeon, orthopedic surgeon from very famous orthopedic traumatology institute that we are really friendly to Institute of Neurosurgery. I am correct, Professor Yakov Fishenko?
Thank you very much. You're completely correct.
Thank you, Kiev Fishenko. We are honored and we have the pleasure to have you among our speakers today. And may I introduce you? I know that you are going to speak about experience in implementing of biportal spinal endoscopy in Ukraine, from beginners to professionals. I'm expecting a very interesting talk as usual.
Thank you very much. I used to use for 3 years monoportal endoscopic spine surgery as Boris Pavlov, but then I'm starting to in my practice biportal endoscopic spine surgery, and very soon it's displaced all another treatment techniques, and now I use only biportal spine surgeries for any decompressive surgery. I'm not using any implants. I'm use only decompressive surgery for degenerative spine conditions. So let me start to explain you my position about the biportal spine surgery. So I'm starting from the advantages from the biportal endoscopic spine surgery. This is very good magnification and illumination, easy target points and panoramic view, less limitation walking space. As one presenter showed us that monoportal spine surgery, this is like anchoring. When you where you find your starting position, you can only walk in this place. But the biportal spine surgery, this is floating, so you can move few centimeters caudal, cranial, and you can make the very good decompression. For this technique, you need 0-degree endoscope. We use only natural gravity. We don't use any pumps for liquor. We use radiofrequency ablation for coagulation. We use burring, and we can do selective decompression. Also, we can use endoscopic lumbar antibody fusion. I am not use it widely, but sometimes it's possible also to make it from this access. So the main principle of biportal endoscopic spine surgeries is triangulation. We have 2 ports, one for scope and for inflow of the liquor, another for walking canal, for outflow of liquor, and for walking instruments. And also we don't have the natural cavity as we have in the joints. So for this technique, we have to make the walking space with removing part of the dorsal elements of the vertebra. So the main advantages of the biportal endoscopic spine surgeries, this is 2 small incisions, low damage of muscles, low damage of spine ligaments, low bleeding, low infection rate, small scar formation. I have a big experience, so I have some patients with new disc herniation and remnant disc stenosis decompression. So if we go there once more, this is no problem. This is low scar formation. We have an excellent view. We have a short terms of hospitalization. The main part of my patients this day or next day are going home. Much cheaper than monoportal and much less radiation than monoportal. We are doing just 2 or 3 images with C-arm. What do we need for biportal endoscopic spine surgery? We need all what we need there for arthroscopic surgery: camera, light source, monitor, shaver, radiofrequency generator, 0-degree arthroscope, and UB instrument set, Kereson rongers, and pituitary rongers. By the best, we can do 2 approaches. The most of them is the interlaminar. From this approach, we can make the decompression from ipsilateral and contralateral side, and dorsolateral or transforaminal access for the foraminal and extraforaminal disc herniation, foraminal stenosis, and far-out syndrome. Interlaminar we use for disc herniations and centrolateral and foraminal contralateral approach stenosis. The best approach, we need to make 2 incisions. So if we need to work on the level L4 and L5, first incision we are making on the lamina of the cranial vertebra. So the first incision is here, and the second incision, the 2 centimeters caudal from the first one. If we need dorsolateral approach, we move 2 centimeters lateral from the pedicula, lateral pedicle line, and also the caudal incision 2 centimeters caudal. When we start our when we just start our surgery, we need to stop blooding. The main blooding vessels is on the 9, 7, and 4 o'clock on our view, from our viewpoint. So on these positions, we have to coagulate. For the bone resection, we can by the biportal spine surgery, we can make the very good bone resection. So we always start from the basic of the spinal process. Then we can make resection of the cranial lamina. Then the part of the SAP, superior articular process. Then we can make the resection of the caudal lamina. Then we move to the contralateral side, making the resection of cranial laminar and the contralateral SAP. Then we make a removal of ligamentum flavum. I can show you in this video how we are removing ligamentum flavum. Ligamentum flavum has 2 layers, the superficial layer and the deep layer. So we're starting to remove it from the distal side. We skewer it. So we skewer it. We start to remove the ligamentum flavum. We start with skewer it, and then we use shaver, which always use the arthroscopic surgeons. So starting from curate, and then we use shaver. With the shaver we can remove very good all the soft tissues. So then we need to remove the deep layer. Deep layer we are trying to remove with the resection of distal lamina. This is the safest method of removal of ligamentum flavum. So with the part of the bone, we make it careful. Do not push to the canal. So that's it. And you can see the intracanal structures, and then we remove this part with the Carison punctures. So here you can see the epidural fat, and under the epidural fat, the nerve structures. So I started to make biportal spine surgery in 2019, and from that period, from 2 years, my experience is grow. And if the first year I done only 83 surgeries, next year 221, and this year I already done 327 levels of decompression via the biportal spine surgery. And some cases, how we remove the disc herniation. So as you see, the view is very good. It's very understandable for the surgeons. It's much more easy than monoportal spine surgery. So, and after the biportal spine surgery, I can be completely sure that I remove the full part of herniation. I have a good experience in monoportal spine surgery, but always after monoportal surgery, I had the feeling that maybe I left something there, but now I am sure that I'm sorry. So in this case, this is extraforaminal disc herniation. So this is the nerve, and under the nerve, we found the disc herniation. So as you understand, the view is very good, and it's very easy to make decompressions and very easy to remove the disc herniations. In my experience, I have a big experience, so I had a lot of complications. So when I started, I had a lot of dura tears, which is mostly it's easy to fix by the tachocomb, and only one I had in this case I had one conversion to the open surgery. I have 18 cases of recurrent disc herniations, and most of them we fixed by the biportal endoscopic spine surgery, only 2 by open surgery. And we had, when we start, we have a lack of decompressions of spine stenosis in 14 cases. Only twice we need to do reoperation. And we have 1 case of radiofrequency injury of cauda equina. So, in conclusion, the biportal endoscopic spine surgery is the best patient care. This is minimal invasive, low postoperative pain, fast recovery, low complication rate, good option for surgeon, easy education curve, and low radiation explosion. And good for hospitals, this is cheaper than monoportal and short hospitalization terms. Thank you very much for attention. If you have any questions, you can ask me in the discussion.
Thank you. I think, Andrei, we have some of our colleagues raising their hands.
Yeah.
All of them are allowed to talk. Dr. Goody, are you here?
Hello, good evening, everybody.
Good evening.
Hello.
Yeah, my question is with Professor Pavlov. Around when he presented with the pelt, could we put an artificial disc or an arthroplasty after doing an endoscopic discectomy, because that will help us preserve the motion, even if the facetal degeneration is around grade 1, grade 2, and a partial discectomy or a subtotal discectomy is not that much helpful. So if we combine both these procedures, will it be functionally better, the spine?
Yeah, Boris, can you catch the question?
Sorry, Mr. Andrei, can you repeat?
I was saying that.
Maybe in shorter way, could you specify your question, please?
I'm asking, can we combine an arthroplastic? Can we do an artificial disc and a pelt procedure together and provide a better stability to the spine? after doing a endoscopic discectomy, can we put an artificial disc also there that will give us a better stability and range of motion?
Ah, I see. Do we some experience in artificial
Disc,
disc after remove? No, unfortunately, on this moment, at this moment, we haven't got such experience. Sorry.
Okay. Okay, sir. So one more thing, compared to conventional open spine surgeries, we know that endoscopic surgeries are better in short-term hospital stay, blood loss, and less muscle tissue and less ligamental damage. Whether the long-term effects are better or same than open procedures, has that been validated? The long-term outcomes of open versus endoscopic surgeries.
So about bleeding and scarring process, I see. Yeah.
Yeah, that's in the short term. Whether in the long term functional basis, like in 4 years, 5 years outcomes, do the endoscopic is better than open, or is it just during the hospital stay and less bleeding, like it is better?
Yeah, meaning what is in other way? Can I, Uday, can I just explain from my point of view?
Sure, sir.
Yes, yes,
Yeah,
please.
I mean,
Thank
is
you.
it so effectiveness of endoscopic? We know that less bleeding and less staying in the hospital, but if
Yes.
you're taking into account about the long term,
Yeah,
about
exactly.
5 years.
Yes,
So
yes,
what
sir.
is the privileges? Because you know, it's from my comment as a moderator when
Thank
we
you.
started when we started many invasive neurosurgery. Many patients started to talk that do not use mini invasive neurosurgery, spinal or cerebral, because it's mini invasive, meaning less effective. But it's not true. So that's why
Yes.
please explain your observation of the long term for 5 years endoscopic, and what is the advantages, or do we have advantages? Is it correct, Dr. Uday?
Yeah, yeah.
Yeah, yes,
Thank you. Thank you,
yes,
Mr.
that's
Andrei. Thank
exactly.
you. So we have experience of 5 years, and see that moving activities in lumbar part with patient who underwent endoscopic surgery better. The first. Second, bleeding in the during the operation several times less.
But functionally, if we're talking functionally after 5 years, so
from our experience, functionally a little bit better in the cases of endoscopic surgery.
From my point of view, I can only add, and then maybe Uday will correct his question, that even the surgery trauma for open surgery, from my point of view, from my patients is worse for patients than endoscopic.
Yes.
Even mentality of patients that the endoscopic, you of course doing well to make a small incision in case of incision. So
Yes, sir.
that's why, that's from my point of view. So maybe you will continue, and maybe Dr. Uday also will comment.
Yeah, thank you, Dr. Andrew. Excuse me for my poor English.
No problem.
Thank you. Yes, exactly, sir. Like the intraoperative blood loss is less, muscle damage is less, tissue damage is less, but patients do develop post laminectomy kyphosis, and is there in my endoscopic surgery also. So that it was a question. It was also put forward to me, and I again placed it on the platform. So I was discussing this. whether it's feasible in the long term for the patient.
Mhm.
Definitely for the short term and the hospital duration, less cost is there. I was searching for more data on the long term aspects.
And I would like maybe Professor Yakov Fishenko also comment on that from his big experience, because we also have common patients that come in from us to Yakov and from him to us, but majority patients moving to mini invasive spinal surgery. Maybe a few words from your experience, Professor Fishenko.
Yes, because a few years, like 5 years ago, I had an experience with open surgery. But last years, when I started endoscopic spine surgeries, I started to have more patients, and I started to make less open surgery. And maybe last year and a half, my experience in open surgery just like a few cases a year, maybe this year I done just less than 10 open surgery cases, but I had more than 300 endoscopic spine surgeries. So endoscopy is much better, and our patients looking for endoscopic options for those cases.
Okay, but what is the intentions from patients to make surgery less invasive, mini invasive? It is one of the first when they come into to our department for my endoscopic cerebral department. They ask, please, please do it less invasive endoscopically.
Yes, sure. They are looking in, I don't know, internet, from their friends, from their relatives, and they are looking for the options of endoscopic spine surgery. And in those days, the endoscopic spine surgery completely displaces open surgery in degenerative spine, lumbar spine diseases, any diseases. This is disc herniation and stenosis surgery. So completely displace the open surgery.
Andrei, I think for patients, when you ask them to choose between both procedures, usually they are going to choose the procedure which makes them go home on the same day. But I want to say something very important, that we have to be selective in choosing our patients. Yeah. And the second thing, we need more studies which are going to be comparative studies between endoscopic and microscopic along the long term. And that's very important. I don't have any information about the studies available now, but my opinion is that they are close to each other, the results, concerning the results and concerning the morbidity. However, the patient usually selects the easier way in order to go home on the same day, to have skin incision, which is very small. And these are people, they are thinking like this. So better discussion to have more discussion with the patient. And I think selection remains very important while doing endoscopic procedures for these patients.
But thank you for that comment. And we also, Dr. Uday, are you
yes, sir.
Are you okay with your?
Yeah, thank you. Nice.
Thank you, Dr. Uday from India. I think Andrei, Professor Uri is raising his hand. Maybe he'd like to ask a question.
Yes, but also from it's what you mentioned, I have to stress that issue. It is very important because from general, so to make, and also as Professor Fishenko said, it's very important to have a clear understanding what patients are selected for endoscopic surgery, endoscopic spine. We are talking now about spinal surgery, because if we will collect all kind of information, from my point of view, I mean, from my experience, because also I manage patients with spinal pathology, general spinal pathology, so less than 10% of all spinal pathology can be managed by endoscopy. I mean, all kind of spinal pathology. But what I know that maybe next comment will be coming from Professor Fishenko, because they do not only degenerative endoscopic spine surgery, but all other orthopedic operations. So maybe in the end, I will ask Professor Fishenko to comment. Okay, who raised the hand? But also we have
Uri.
Maria, but okay, Uri, but we have also Hakim and Mariam.
And Mariam, yes.
Mariam, yes.
Yeah,
Good
yes,
evening.
let me introduce Mariam. She is Egyptian neurosurgeon, and she is working as lecturer in Azhar University in Egypt. Mariam, go ahead, please. Introduce yourself
Good
and
evening.
speak.
Good evening, everyone. I have a question. Can I ask?
Yes, yes, of course.
Okay, I have a female patient, 35 years old. She have a disc degeneration, lumbar 2, 3, and mild degeneration in lumbar 1, 2. The disc in lumbar 2, 3 level has a central prolapse compressing the coda. She tried physiotherapy many times, also medical therapy many times, but all are failed. Which the best can I do for her? Can I do radio frequency for lumbar 2, 3 disc with epidural injection? Can I do open surgery with fixation? Which level I fix? Dorsal 12, lumbar 1, 2, 3. Which is the best for her?
Mariam, it would be great if you show us the images. You can share your screen. Do you have the imaging of this patient?
On the telephone?
I don't think you can share
the telephone, not the laptop.
You can share from the telephone, I think, except if it's iPhone. Do you know how to share from the telephone?
Dr. Nasser, the images?
Yes. Can you share? Can you show us the imaging from your phone?
I will try. Okay, I will try.
Okay. Until you try, I give the mic to Dr. Andrew Hook to start discussion about this patient.
Okay.
Okay, and
can you say again, Mariam, summarize this patient has coda equina?
Yes.
And sequestrated disc.
No. She complains only from back pain and severe muscle spasm. But the disc lumbar 2, 3 is centrally compressing the coda.
It's huge disc?
Not huge disc, a mild to moderate compression.
Okay.
Okay. I will share the photos to you, Dr. Nasser, on WhatsApp, and you can share it. It
is okay, but you have to transfer to a computer. We can't share from the mobile.
Okay, I will try. Okay. I will try to share it.
While we will do that, maybe I will give some words to Yuri Lenkowski, Dr. Yuri. Yeah, please go ahead.
I want to say incredible thanks to Professor Fishenko, who opened for me the magic world of UBE technology. He performed the first operation in our city in Kamyanets-Podilsky 2 years ago. And after that, in our clinics, we performed about 200 of UBE. And I want to say some words about opinion of patient and about choosing the treatment, UBE or open surgery. I have opinion in experience in open surgery more than 20 years. I don't know how many open surgeries on spine I performed. I did only last 2 years UBE, and I didn't see any cases which doesn't possible to do by UBE. All herniation is possible to do by UBE. It's a true. And from our patient, only 1 or 3% choose the open surgery, because UBE is a magic method. It's achieve us to remove any herniation. But besides, I have a small question to my friend, to my teacher, to Jakub Fishenka. I also have to say you thank you so much, but I have some question. I answered this question you many times, but maybe now some change. How do you perform hernia from the right side? Do you stand on the right side of the patient, or you performed it from the left side? Thank you.
Thank you, Yuri. I perform it always from the right side. From which side is herniation, I perform the surgery from that side.
Okay, but in this case, you have to change your hand. If your right hand doesn't work as left hand, it's very difficult to do surgery by the left hand. Or you change arthroscope and can you answer this?
It's not easy, but the first cases it's not easy, but then you have an experience and this is no problems. So now for me to remove the disc herniation, it's 15 to 20 minutes from, it doesn't matter from which side. And one level of degenerative spinal stenosis, it's about 30 to 40 minutes. So this is no problem. It doesn't matter from which side I have to walk. I can walk from any side.
We walk from the left side. It's not depend on the level of the right of or on the left. We performed directly from the left side. And the last question: do you perform local anesthesia on the UB techniques?
I am not. I like general anesthesia. It's much easier to control the blood pressure, to control the everything. It's much easier for my anesthesiologist. I don't play that games like local anesthesia, epidural anesthesia, so we don't need it. General anesthesia is very good. In a few hours after surgery, patients can stand up and walk, and this day, if it's disc herniation, or next day, if it's spinal stenosis, they can go home. So I prefer only general anesthesia.
How many days patient will in your hospital after surgery?
A disc herniation the same day or next day, and spinal stenosis patients, if this is 1 or 2 levels stenosis, the next day. If it's more levels, maybe a few days more.
Yes, and very important, may I comment that we know that it's now very, at least in Ukraine, we have very intellectual patients, and to having local anesthesia, even he will try to suggest you as a surgeon what to do. In general anesthesia, so it's a joke, of course. but yeah, but it's, of course it's a joke, but sometimes it happens because we provide in cerebral neurosurgery wake-up anesthesia, and sometimes have to be very silent in our operating room to avoid any misunderstanding with our patient. Okay, so
I have
about 10% of our patients we provide local anesthesia, combine
with
epidural and local anesthesia.
Okay.
So,
if patient very patient, it's possible to do.
Can I ask Mr. Lankowski?
Yes, my friend.
Maybe I'm sorry, Boris, I'm sorry. We had Hakim questions, but now I don't see Hakim raise up his hand.
I have short questions only.
Okay,
one.
yeah, please.
So for Mr. Lankowski, do you use discography before procedure?
No, I don't use, because we have not very good experience about discography, because if you carefully planning your surgery, all contraindication about nucleoplasty, you can see on the MRI, and it's the one position. The second position, then we insert the contrast inside the disc. The impedance of go down, and that's why it's very difficult to achieve a needful temperature in the disc. That's why we don't use discography. And besides, also then you put the needle inside the disc. You did discography, and if you have some information about cutting of annulus fibrosis, do you stop your procedure? Not.
Okay.
You inside the disc. I'm sure you don't stop the procedure. You finish it.
Okay.
That's why we don't.
Thank you.
Discuss.
Thank you.
You're welcome.
Okay, we glad to see that Professor Smolanka back for discussion. Thank you.
I was all time here, but I have a.
I know.
I have an episcopal from Rome here.
We know.
So I was following you.
Oh, good. Because we have while we have some questions from the flow. So one across pocket, because we know that you're universal neurosurgeon, Professor Smolanka, and so we have one question: why remove surgically during cavernosis in brainstem? Such a question was from why remove surgically, and just another one. I mean, hemostatic material. Why not use hemostatic material instead of removal surgically? Yeah.
No. I understand. So I showed during my thanks to.
Oops. Hopefully, will join us a little bit later. Something wrong. Okay, so moving ahead. I think Professor Smolanka will back to us and will answer. And do we have questions? We have from Andrei Burunov question. Just comment. If you use a microscope in open surgery, your view is good enough. What do you think? Again, it's good question. So, and
I am sorry. I'm sorry.
Back. Yeah, you're back. So
I am back.
So, okay. And another the second question.
I know. I understand this question. And
Professor Smolanka, just when you was a little bit out. So another question to you as a universal neurosurgeon is that from Andrei Burunov from Ukraine, that if you use the microscope in open surgery, your view is good enough.
Yeah, okay. Thanks.
So,
Thanks. So answering the first question, I understand the question because I have shown the video brainstem cavernoma removal, and during the removal, then at the end, before I have finished the operation, I put a hemostatic agent. It was a Surgicel there to the place there from which cavernoma was removed, and then I took it out. I took it out. So the reason is that sometimes this hemostatic material, there is some brain swelling after the operation, possible brain swelling after the operation. So I suppose that this hemostatic material could be a factor of compression. That's why, of course, temporary compression, and there could be some adhesions there. So that's why after 4 or 5 minutes, then I see the hemostasis and clean operative field. I usually take it out. It seems to me that it's more mini-invasive, as you told, yeah, Andrei.
Yeah, okay, thank you. But as I had
Less
joked,
invasive, I would say, less invasive.
yeah, I had joked that you know, from the very beginning when we started operate with endoscope, a lot of our many invasive, many patients was very skeptic, and our colleagues told us that remember to other patients that less invasive automatically meaning less effective.
Yeah, that's not
Yeah,
true.
but we know that it's not true. Okay, so and also the question was when we move into another regarding the for spinal surgery that from Andrei Burunov, that in his opinion or his comments that microscope is good enough to use microscope in open surgery, your view is good enough. So what is your comments? Again,
Yes.
microscope versus endoscope.
Yeah, this is interesting question, and those guys who didn't use the endoscope, they completely sure that microscope is also good. But and it's difficult for those guys to move to endoscopic spine surgery because they mentioned that microscope is the same as the endoscopic spine surgery, but this is not proper. The endoscope is much less invasive. In endoscope, you have much better view, you have much better magnificence, and everything better because the water circulation remove all the blood, and the picture is much better. So I think that endoscope is much better.
Can I express my opinion?
Yes, please. Yes, please.
Yes, please.
Yeah, I am a surgeon who does both techniques, endoscopic and microscopic. And of course, if surgeon has a possibility to do both techniques, he always will find a proper technique for each procedure. So we cannot say that one technique is better than another, or other technique is better than this. Sometimes we use endoscopic technique, sometimes we use a microscopic technique. For example, this is a common example. We shifted almost fully from microscopic, or fully from microscopic to endoscopic technique. Then we do surgery of sellar region, I mean the adenoma surgery, hypophysis, adenoma, pituitary adenoma. But there are other procedures, I mean brain surgery and also spine surgery, so which are better done by microscopically. But anyway, if like Professor Yakov Fishenko, he's an excellent endoscopic surgeon, and the endoscopic surgery is excellent in his hands, that means that it's very good that he does, and he can do all the procedures, or almost all of procedures endoscopically. If anyone is very good in microsurgery and he has good results in, for example, including the brain surgery or spinal surgery, he can use that technique. But I think that the truth is always in between. Yeah. So we have to use that technique which is more proper for certain definite situation, and for each patient, it's that's another story. Yeah, thank you.
Okay, good. And Nasser, Professor Nasser, we now have
Yes.
please.
Yes.
We have an image now.
Yes, I think just a few words about what Professor Smolanka have just said now. Two important factors, the experience of the surgeon, the growing learning curve That's very important. It has a very strong impact on the results. The second factor is selection of patients. I think these two factors are very important in order to operate by endoscopic surgery for degenerative spine.
Okay, and now
Mariam, are you ready?
Yes,
Mariam, she
yes.
wanted to show us a case, and she is
Yes,
sharing
Dr.
her
Nasser.
screen. Please just speak about this patient, a resume.
This female patient, 35 years old, complaining from severe back pain and muscle spasm only. This female patient has lumbar 2-3 and lumbar 1-2 degenerative disc, lumbar 2-3 on axial cut, compressing the central part of the cord. The exit neural foramina are free. This patient tried to physical therapy, medical therapy, but all of this are failed. So this female patient, I want to do a radio frequency for lumbar 2-3 and lumbar 1-2 with epidural injection. What also can I do for this? Can I do an open surgery with fixation? Or she not benefit from open surgery and fixation? Will lead to more lysis.
okay, who will be the first?
I have to say that we need more projections. That's not enough to decide. As for me, relying on these images.
Axial cut? Can I share the axial cut?
Yes, of
Yeah, of
course.
course.
Okay, 1 minute.
Okay, and having the time, may I also
The
say?
axial cut.
Oh, okay, yeah.
Yeah.
Mhm.
What's your opinion, my professors?
Very small picture.
Yes, it's a very small picture, Mariam. Why don't you enlarge it?
Okay, 1 minute.
Do you have simple X-ray?
Yes.
Do you? X-ray,
Yes.
simple X-ray. Do you?
Cardiologist.
I suspect vacuum phenomenon will be on this level, and we will see it on the X-ray or on CT.
There's an X-ray. This is the X-ray for the
Mhm.
for this patient.
Lateral.
What are the clinical symptoms?
Severe back pain with muscle spasm only. We try physical therapy and injection for sacroiliac joint, but failed.
Do you have improvement after injection of steroid to sacroiliac
What?
joint?
What?
Do you have improvement after sacroiliac injection of steroid?
No improvement. No
No
improvement.
improvement. Any improvement?
No improvement.
Maybe facet syndrome will
What?
be here. Facet syndrome, maybe, no?
Facet syndrome? Maybe.
You can combine not only sacroiliac injection of steroid, you can combine this facet injection too,
Okay.
because they were very similar. Facet syndrome of L5S1 and the sacroiliac pain syndrome is very similar. And it's
Okay.
very difficult to know exactly about the aim of pain.
Okay. This picture show mild rotation in the lumbar spine with the sacroiliac joint right from the left.
You have lateral view.
What?
Of X-ray. Lateral view of no AP. Lateral view of X-ray.
No lateral view available. This is the only picture available. This rotation from the lumbar disc, from lumbar 2-3, the transverse process of lumbar side is rotated somewhat to the right side, to the right sacroiliac, more than the left. This is a complication from lumbar.
It's a male or female?
Sorry, can you?
Male or female?
What?
Female.
What
This
sex of
patient,
the
this patient, male or female?
Female.
female?
Mm.
Does she has a worse after standing up or
Yes, standing.
yes?
She acts as teacher.
He's a teacher, yes?
Mm.
I think you have to combine epidural steroid injection. Maybe you have to use radio frequency of facet joint.
Radio frequency for the facet. Okay.
Yes.
Which one? Facet lumbar 2, 3, 5?
You ask about the generation of on L1, L2, L3, yes?
Yes, okay. I asked about this.
But there are no compression of dura on this level, on axial view, as I see.
Mm.
There are no compression. Maybe the case of pain may be inside the disc. That's why I try to see the lateral view, because sometimes we have a vacuum phenomenon and it depends on the seat position when patient change the position and he feeling worse.
Mm.
It may depend on existing vacuum phenomenon as well, but we cannot see it on MRI.
No X-ray lateral view available with me.
And no CT.
So I will try radio frequency for the facet with epidural injection for the first.
If vacuum phenomenon will be confirmed, vacuum phenomenon will be confirmed, existing a technology which named discoplasty. I know many surgeon doesn't like it, but in Hungary it's very popular method.
Mm.
Discoplasty. Then you have vacuum phenomenon, and when you have a pain which was after standing up, it's very easy to put inside the disc space to do augmentation or some cement, and pain may be relieved. But you have to do a full assessment. You have to examination. You have to do CT, and then we have full information about level L1, L2, and L3.
Okay.
Because no compression of dura on this level. Maybe it depends on the size of the MRI. It's better to evaluate a digital MRI. It's very difficult to see the small picture.
Okay.
Maybe send on mail the MRI in digital form.
Digital MRI. Okay. Thank you, Professor. Thank you.
But in this case, I sure you have to try all pain management technology, including radiofrequency ablation, including facet joint radiofrequency, and steroid injection.
Okay. Any other suggestions? Not? Are you agree with what proposed by Yuri Lankovsky?
What about facetal implants?
Yeah.
Facetal implants, if we can use facetal implants there,
I don't understand.
Can we use facetal implants?
Facet implant?
Facetal implants.
I don't know what you mean by facetal implant.
Could you please explain, Dr. Uday, about facetal implants?
Like we can.
Is she overweight?
We can put small implants. There are facet for joint restoration, for degenerative facets. they are implants which we can place in the facet region.
I
Okay,
think this is
I-
not available in Egypt, I think.
Nasser, maybe could you please explain
Mm.
about the,
We don't have that. I think we know we need more information. Are you doing such procedures in many centers in Ukraine? We don't have this.
It
it's
was just a suggestion. It's being used in US. They use like the new generation facetal joint implants. We can replace them, put them in between the facetal zygophyseal joints. They can provide some kind of stability. I read an article about it.
What type of implants you mean?
Like the small the zygohypophyseal joint implants that can be, which are clip-like implants and egg-shaped implants and can be placed.
Would you have any experience about that?
I have read articles. I was reading an article, facetal replacement. I was reading an article about that.
Okay. Oday, you have many centers in India doing such procedures. We don't
Very
have
less,
we don't do
less.
that here. But I'm speaking about
Yes,
India
very
and about
less.
Ukraine. What do you have in India?
Less, very less, very less.
Very small number of centers.
Yes.
What
very
about
less.
Ukraine? Who do you have such procedures?
I don't know. In our institute, we don't use this procedure. Maybe Yakov Fichenko?
No, I never heard about this procedure.
No, here. Professor Smolanka?
No, I have no idea.
Okay, so moving ahead. Mariam,
Yes.
so I would suggest to, in case of next needing next consultants from Yuri Londkovsky or Smolanka, so you can find out our email address or Professor Nasser El-Ghandour will share.
Yeah,
So,
sure.
Yeah. Okay. So please.
Okay, thank you.
Please, we can continue, and it is very interesting for me personally as a doctor, what the next step will be done and what the results you will achieve. Okay,
Okay, thank you, doctor. Thank you.
Nasser?
Any other questions or any other comments?
No, thank you.
Okay.
I think we can finish.
I think it is time to close the webinar. May I ask Dr. Andriy Hook to say his closing remarks, and maybe Dr. Smolanka as well. I will be happy.
Yeah. Okay. Again, thank you very much for such opportunity. As I told from the very beginning of my speech, I'm very happy that our community growing. I'm a neurosurgical community growing, and thank you, Nasser, for doing organizing such very effective webinars that we start to communicate very openly, and not unfortunately we cannot do that on offline. So we prefer to do that, and thank you to be invited for the very big event that Egypt will host. We do believe that we will meet in personally with every lectors and many our participants. I am really happy that we organize such a collaboration between Egypt, between the WFNS and the Ukrainian Association of Neurosurgeons. Thank you again. Thank you all participants, and thank all speakers for very informative and very good lectures.
Thank you, Dr. Andriy.
Thank you very much.
Professor Smolanka, do you like to say something before I close the webinar?
Yeah, thank you very much. Thank you very much for this opportunity to say a few words. First of all, I would like to express my gratitude to you, Professor El-Ghandour, as organizer of this excellent webinar and this excellent series of webinars. And that's one of our main goals as more experienced neurosurgeons, to teach our younger colleagues, and you give an excellent opportunity for us to share our experience and to hear the voices of young neurosurgeons, their opinion. They know a lot, but we can share our experience. And thank you very much for this. I personally appreciate my invitation to this webinar. I am sure that we will continue with this practice. I mean, these webinars with you, and I would like to greet all young neurosurgeons from all the countries all over the world, and to thank them that they are very active and they are eager to get more and more information about from our beloved specialty neurosurgery. Thank you.
Thank you very much, Professor Smolanka. You are always great, and appreciating that we took from your time such a contribution. We understand, according to your position as president of one of the well-known Ukrainian universities, that you are always busy in meetings and responsibilities. And in spite of that, you insisting to share and promote neurosurgical education. And also, I would like to thank my friend, Dr. Andrew Hook, for giving me and for giving all Africans and Egyptians such opportunity to have such collaboration with the Ukrainian Association of Neurosurgeons. The discussion was great, and I apologize that we extended the webinar for 1 more hour, but actually the discussion was very interesting. All the talks were outstanding. I would like to thank at the end of this webinar all our distinguished speakers. May I not forget to thank my organizing team, Dr. Hassan Ali and Ahmed Magdi. And I hope that we gather again in another event soon. And we will wait for you, for all of you in Egypt in the Third Demands Congress. And we will see you in Bogota in March 2022. I would like to thank everyone for contribution to this important event. To remind you that our webinar, next webinar, webinar number 54, it will take place on Friday, 26 November at the usual time from 12 to 3 GMT. Thank you very much for everything, and see you later.
Thank you. Thank you. Bye.
See you.
Thank you. Thank you very much.
сказали? Ні, ну. Опять захопить нашу асоціацію. Я кажу, Льоня, ти хочеш, щоб я написав? Я написав аж з душі. Фу. Написав собі. І в мене з душі. Так, нам не буде.